So welcome everybody today yet through this another Surginar live telecast of interesting cases. And we are today in the operation theatre of none other than Dr. Ashok Nanda, who's the medical director of Car Vision Eye Hospital, Bhubaneswar. He's done his MBBS from MKCG Medical College, Berhampur, Odisha, and also done his post-graduation from the same institute. He's done fellowship in comprehensive ophthalmology from L.V. Prasad Eye Institute in Hyderabad. And to his credit, he has numerous awards, which include gold medal in ENT and ophthalmology, best paper award in International Society of Manual Small Incision Cataract Surgeons annual conference in 2017. And he's been the editor of editor journal of Odisha Journal of Ophthalmology, treasurer of Odisha State Ophthalmological Society, General Secretary of Odisha State Ophthalmological Society, and Organizing Secretary of the Annual Conference of Glaucoma Society of India. We all have been beneficiaries, or we all have experienced the hospitality which Dr. Ashok Nanda actually entails when we all go to Odisha. And it is a pleasure and an honor to be there with him in his operation theatre today. So we are live from Car Vision Eye Hospital, Bhubaneswar, and I have with me my co-moderator, Professor Rajesh Sinha, Honorary Treasurer of All India Ophthalmological Society, and Consultant Cornea, Cataract and Refractive Surgery Services from RP Center, All India Institute of Medical Sciences, New Delhi. So over to Dr. Ashok Nanda.
Thank you, Dr. Namrata, and thank you, AIOS, for having given me this opportunity. I was told to look for some interesting cases, but since it is a sponsored surgical session or webinar, the lenses that are supposed to be used, I did not get interesting cases to use those type of lenses. So I'll be probably discussing more on basics of surgery and basics of using the machines, its parameters. So I'll be doing 4 cases on 2 different types of lenses from J&J. The first case is a 61-year-old male. I think you can just switch on to the microscope view. So for all the cases that we do a good preoperative evaluation, which is very essential. And we all know that nowadays everybody is interested in doing surgery with minimal postoperative refractive status. So the patient should be emmetropic, that's the goal. So for that, we need to do some planning, and we must look into the keratometry and your position of the incision. So we use variant to mark our axis. We do can I have the slides for this patient? So this gentleman is a 61-year-old male having cataract in both eyes with a best corrected visual acuity of 6.9 in one eye, right eye, and the left eye is 3/60. He has a nuclear sclerosis and a PSC in the left eye. K value is 41.86 and 42.34 with a cylindrical power of 0.48 at 150-degree axis. We are going to use EDOF lenses, Technis eye hands, power of 25 diopter. Next. So this is what we do, and I keep slightly on the myopic side. So the power is 24.5, and I have given 25 to keep the patient slightly myopic, forward 0.5, 0.6. Next. And of course, we do a variant to find out. In this case, if you see, the patient requires additional incision across where you have to give the main incision. This is to neutralize the 0.5 cylindrical power which is there. Next, please. And of course, we do a OCT in all cases. So let me start my surgery. Okay, the first step in this is to register the patient under the variant machine, and it gives you. Take it off. Take this.
Any reason for doing OCT in all the cases? Like you want
I'm not a retina surgeon, so in my scenario, I have seen at least about 10 to 15% cases where I find the retina is normal. The patient comes back after the OCT scan is done. The optometrist sends him back with some of the reasons which would decrease postoperative visual outcome. like a VMT or a small IS-OS junction defect. So these things you can never know unless you are a real good retina surgeon.
Okay, yeah. And you can have baseline values also so that you can explain to the patient that it was there beforehand.
Exactly.
Not because of the surgery.
Torik, hey, this thing go to change kara. So almost all of my cases I do under a soft cell technique. I use viscoat and then methyl cellulose. Because I use viscoat, I have stopped using cystitome because that makes the surgery slow.
So do you think, yeah, like you said, that when you're using viscode, the surgery, the capsulorhexis is not very slow, but it retards a little bit of the capsulorhexis maneuverability, which you would do, for Visilon, etc. Although it is much more controlled. Do you think that would make any difference?
Yeah, definitely. If you have less number of cases, doing it with a cystitome makes your axis much more circular than with a forceps. But as you said rightly, it is more viscous. So folding the capsule and rotating it becomes a little more difficult. Okay. And I normally have two techniques of my phacoemulsification. If I have a soft cataract or a very hard cataract, then I do a stop and chop technique. If it is grade 3 or grade 2 or grade 4, then I do a direct chop.
Okay.
So this is a brown cataract, grade 3. Light ko dekhun to again. Good. So I first bury it from the center, go a little periphery and do a vertical chop. Slowly separate. Most of the hard cataracts you'll find.
Yeah, it's a very good, I would say, a very good technique that you chopped it from one side and then rotated diametrically opposite side so that you could separate the two pieces nicely. So that was something, a very good way that has been shown, a good message for everyone. Because once the nucleus is divided into two pieces, well separated, life becomes much easier. I would just like to inform everyone here that I had the privilege of performing live surgery along with Dr. Nanda earlier, but that was quite long back, and it's really a great pleasure to see him once again, doing surgeries, peeping into his operation theater, into his microscope. So, really thank J&J for
So if you have noticed here, whenever you have a harder cataract, you will usually have an endonucleus.
Yes.
So you cannot crack the central part. So you need to not worry about that. You just keep on tracking around the nucleus, and finally the endonucleus comes out in the middle, and then you can of course pick it up. The interesting part of this machine is that the chamber stability is really good.
Yeah, with a very good followability.
Yeah, good followability, good chamber stability. And if you have a hard cataract, you can think of changing the fusion fluidics. That means you change over from your peristaltic to Venturi if you want to use it in a very hard cataract after you have chopped it.
So you are using Signature Pro?
Yes, yes. Light ko dekho. So my phaco settings are in the quad mode. I use a flow rate of about 40 and a vacuum of about 500 and a power of about 30 to 40 depending on the hardness of the nucleus.
Okay.
I have a variable white star where I keep my on time 20% in the initial part, then gradually increase to 30-40% in the second later part of the foot pedal.
And you always prefer doing bimanual irrigation aspiration?
Yeah, that's my choice. I have been always been very comfortable with that. I feel the polishing is much better using a bimanual one. And I also do not have a habit of using the polishing mode.
Okay.
In my machine, I keep the vacuum to 400, which is panel, and my flow rate is something around 20-25, which is controlled by the foot pedal. So it is a linear mode. So when I feel that I'm polishing and the capsule is getting caught, I can control it easily by decreasing the flow rate or decreasing the pump movement.
So this is something that can happen in cases of little harder cataracts, wherein you can get some small piece.
Yeah, the small fragments chatter and go into the periphery.
Going into periphery, getting stuck somewhere.
I think a very nicely done case. For the first case, it was almost like a textbook-like picture, showing each of the steps so well.
And you are doing hydroimplantation.
Yeah, that is again to save time when I have a lot of cases. So this is better, and more so. Almost about 30% of my patients are toric patients.
Yeah.
So that's another reason for converting into.
What lens are you implanting?
This is eye hands from the platform of Technis. So in implantation of eye hands, I always make sure that I do a pentacam also, where I see the C value. If the C value is in the normal range from 0 to -1, then I definitely suggest. In case it is more either on the hyperpolite side or a more minus, then I do avoid.
I think there's a small pterygium there, which almost, or it's just a encroachment of a little bit of conjunctiva onto the cornea on the other side. So are you going to do something about it, or we'll just leave it like this?
I normally leave it like that because the amount of cylindrical power in this gentleman is 0.45.
Yeah.
And having done a 2.2 incision, I think post-operatively it will be around 0.25.
Yeah.
So why unnecessarily fiddle with it? It looks atrophic.
Yeah.
And patient is not paying, of course. Okay, ma'am. So
perfect.
Wonderful, wonderfully executed first case.
First case and finished in record time. I mean, it was too fast. There is a very beautiful scenery which is there in your operation theater, which I see at the back. It looks, although we are not in operation theater, we are somewhere else actually.
Yeah, actually, when I started this OT in this hospital, I did not feel like operating in a steel box.
Yeah.
So when I asked these people who are doing the modular theater, they said it would cost you about 1.5 lakhs more, but you can see good sceneries on the behind. So I chose one, and they agreed to put one glass cover. And put it. So in both my OTs, I have put one wall covered with glass, glass and the scenery behind that.
Okay.
Out,
And your operation theater is entirely modular as it looks by the steel walls.
Yeah.
Yes, it is.
What do you think? What is your experience about eye hands? From monofocal lenses like Technis to eye hands, how often you switch over? Like, is Technis still in your practice, or you have mostly shifted to eye hands?
No. I personally like eye hands because I would say more than 75% of patients do have N8 or N10. 75%. There are surprises. So the trick of using eye hands is never promise a person that I'll give you fairly good vision, you can work with computer, because there are surprises. So it does happen. But you can actually tell the patient that this is the latest, which can give you some extended depth of focus, whereby in most of the times you would not require a glass when you're looking at a telephone call who is calling you, or maybe when you are working on a computer a little far. So it should be fairly okay, provided you do it in both eyes.
Yeah.
And in more than 75-80% of people, if they are happy, so they get almost bilaterally. If you do it, N8 is feasible.
Yeah. That's
so you would adjust your fellow eye power depending upon what your one eye post-op refraction is, or post-op correction is, or post-op vision is.
Sorry, I couldn't get you.
I'm saying you would suppose you were to have, say, 6/9 and say N8. Would you then adjust your power in some other manner in the fellow eye, or if you were to have, say,
that depends on the person's,
or maybe 6/6 in one eye and say N12 in that eye, and then you would like to make the other eye a little myopic, so that
becomes N8 and 6/6.
Yeah, that I always do, but then see, it all depends on the patient's type of work he does. Suppose he's a person who has to read a lot. I do not want to give him a monofocal type of scenario. I would prefer to give him 6/6 for distance and a reading glass. But if somebody has less of reading, a lady, then probably I would be happy to give -0.5 or 0.75 for distance. I mean, post-operative refraction of that, and a better near vision, so that she can be without glasses for most of her work. So it all depends on what type of people come to you for the surgery and how you counsel about that. But if I do both eyes together and counsel the patient for eye hands in both eyes, I do plan for a monovision, where one eye I try to keep 6/6 for distance and N10 for near with this, and the other eye 6/9 or 6/9 parts for distance and N6 for near, with a target refraction of -0.75. And I normally don't test for which is the dominant eye, which is the recessive eye. It really doesn't make much sense in doing all those tests.
So in this particular case also, you have put -0.5 more than the metropic bar.
Yes. This patient had a plus 0.548 cylinder, right? So even if you correct with the 2.2, it will still correct only 0.2. So he is left with 0.28 plus cylinder, right? Now, if you target a slight myopic, that would neutralize the plus cylinder that is there. So that was the main objective. And of course, if the person remains slightly myopic, it's still better for him.
Yeah.
He is 61, retired. So 6/9 distant vision will be happy.
Yeah.
So can I have the slide for the next patient? I have actually two beds here, but I cannot prepare the other bed because all the 4 patients are left eye. So I have to, wait, get the patient transferred, prepare the next patient, and then. So that's good.
That's good. We have some time. Yeah, we have time for discussion also. So you are going to be operating a hyperope, I think, power of plus 26 diopters.
Yes. Can the slide be zoomed a bit? Yeah. So this is another patient again for the left eye with vision of 6/60, left eye cataract, similar cataract to the other patient, having a cylinder of 0.56 at 150 degrees. We will again use my hands with a power of 26 diopter. If you look at the next please. No, previous one. So if you look at the axial length, it is normal 21.39, but because the keratometric value is 46, 47, the patient has a hyperopic correction.
And what is the ACD? Anterior chamber depth is 3.4. Okay, so that's also fine. Because hyperopes, can be otherwise very challenging if the AC depth is less.
Yes. All right.
And this
so you can switch the microscope view, please.
10 years.
Sorry, Rajesh, anything you said?
Yeah. This patient is diabetic for 10 years. So in such cases, it is, many surgeons are preferring eye hands over any multifocal lens or a monofocal lens, because eye hands not only is a monofocal lens, but also provides some benefit of the defocus curve. So some degree of multifocality is there without having any problems related to multifocality, particularly in diabetics.
Okay, so that brings us to an interesting question.
Yeah.
Of ma light ko dekhiwa siddha halani. Of whether you should be going for trifocal and multifocals in a patient with diabetes with or without retinopathy. So what is your opinion, Dr. Namrata, that suppose somebody is a 10-year-old diabetic having mild NPDR, patient's age is 65. What do you think? Mild NPDR, patient is 65, 10 years diabetic.
I guess. Okay, let me take that question.
Yes.
Patient of mild NPDR, age of 65. I would also like to know what is the duration of his diabetes, because I would like to know what is his usual control of diabetes. So if it's a, say, 15 years old, 15 years history of diabetes, and at the age of 65, mild NPDR, nothing wrong in that, one may consider thinking about if there's a good glycemic control, good HbA1c, one may consider doing multifocal after explaining this to the patient. But having said that, in any case wherein I see any retinopathy, I prefer monofocal lens, and particularly these days with this new variant of monofocal lens, that is eye hands, that has come up. So it gives some degree of defocus. So at this stage, at this point of time, I would prefer an eye hands lens in such a case who is having a mild NPDR and diabetic for so long.
Okay. So here I would probably differ a bit. A patient who is diabetic for 10 years, 65 years of age, having mild NPDR.
Yeah.
If we, and the patient is interested in multifocal. So if we give, what will be the scenario like? It is likely that a mild NPDR will progress to a moderate or severe one in about only 20% cases over a period of 10 years. Okay. So by the time the patient develops intervention, the intervention means surgical intervention. So the patient will be 75, right?
Yeah.
So I think that's not a bad deal that you have given a spectacle independence to a person for 10 years. And the only thing is just look at what is the status of macula, whether there are any ischemic changes happening there or not. That is very important, because you do not want the macula to be affected in a multifocal.
True.
If that is not there in the
That's why I
changes
said.
are-
That's why I said that a good glycemic control by the record of HbA1c will suggest us whether it is going to progress into any maculopathy in near future. It's not going to. So that is why I keep glycemic control as a guide in
Okay.
deciding in these cases.
So that was absolutely effortless, Dr. Ashok Nanda. In one sentence, you completed the whole FICO. So before we could,
True.
So I just wanted to know, I saw you using a capsulorhexis forceps. What forceps is it? Because it didn't look like a
So
Tata.
ma'am, it's
And the control was perfect, huh?
Haldipur one.
Haldipur Karma forceps, okay. Because the control was absolutely perfect and
So do you get some advantage with these diamond dusted, cannulas?
Yes, actually, only when you get those little small epithelial
Pearls
flex.
attached to the capsule.
Flex, which are attached, there it is beneficial. If you do not have a diamond dusted tip, you can just use your hydro cannula to flush it. That is also fine.
Yeah.
But that's an additional step.
Yeah.
So while doing polishing, while doing aspiration, if you can polish it, that's fine. Otherwise, you aspirate out and then take a cannula and flush it like this.
Yeah.
Flush it on the area which is having those epithelial cells, and it will clear up. Any other suggestions that you have when you plan to implant? What about the angle alpha? Because these are prolapse surfaces.
That has to be really taken into consideration, especially when you're doing multifocals, or for that matter, even when you're doing eye hands or EDOF kind of lenses, although EDOF is more forgiving as compared to the multifocal IOLs. I just wanted to also ask you about the injector that you were using. Is that a push injector by the J&J only?
No, it's a screw type.
Screw type.
My assistant screws it inside. I just hold it.
Okay.
I've become lazy because most of my assistants have made me lazy.
Yeah, they've learned everything what to do. No, I just wanted to know, you do have experience also with the AutoCert of Alcon, which we all have become so comfortable with that we are, pushing other kind of lenses also through the AutoCert. So what would you say, how would you compare AutoCert with these kind of injectors?
Yeah, AutoCert is good, but what I have felt is that at times somehow the front haptic, many times I have seen it doesn't fold properly. That is something where I have found it a little difficult. So I have stopped using AutoCert, and screw is easy for me because somebody is screwing it, so I just have to hold it to the wound. And but yes, if somebody is comfortable with AutoCert, I do not personally use AutoCert too much in my OT.
Okay.
My colleague Anurag loves it. Oscar. Yeah.
Okay, I think at a very record speed, we are just touchwood getting the cases done, and they look so effortless that there are no questions to ask actually, as far as the steps are concerned. Because
actually, Dr. Nanda has a very long list, and so he has to finish those lists. that list also.
Yeah, I was asking Dr. Ajay that I have 16 patients. So I just completed, I think, 2 and 3 patients. So I'm seeing them there, and you're asking me to look at the camera. It's difficult, no? It's okay.
Yeah, yeah.
फेस टू फेस बात करना होता है, कैमरे के सामने कौन बात करता है? वो एक्टर्स लोग करते हैं.
Oh.
Right. So, so if it is possible, if you all agree, then after the 4 cases are over, I can probably, if there are some more interesting cases, maybe we can go ahead. If you allow the transmission to occur till 5 o'clock, maybe we can cover about 7-8 cases or like that and keep discussing.
Yeah.
Somebody has asked a question.
There is a question there, and it says that for practicing general surgeon, what should be the choice of IOL? I'm sure, Dr. Nanda, you have experience of all 3 that has been asked, trifocal or eye, hands or vivity. And I think this question keeps coming up as to when would you persuade your patient for a, eye hands kind of a lens, and when will you say, okay, now you can go for synergy, or when would you say that we'll only put a monofocal? So there is of course, economics do play an important role when you're deciding the lenses, because ultimately the patient is going to be paying for it. So how do you decide which lens to ask the patient to, buy?
There are 3 points which I've told my counselor to talk to the patient. The first point is you must explain that these are the lenses available. I have had bad experience of people coming and shouting back, saying, why did you not give the option of multifocal or trifocal lenses? Because he was a patient undergoing surgery through insurance. Insurance does not reimburse trifocals. So the insurance guy who was dealing with the patient did not say about the trifocal or multifocal lens and gave the best one, monofocal. So it should be mandatory, whether the patient is paying from his pocket or through insurance, option has to be given that these are the lenses available in the market. It is not wise that the patient or the attendant learns from Google and comes back and tells you. Then you look into the criteria, whether this particular lens is suitable for this patient or not. So once you've given the concept of the lens, I told my counselor, if a person agrees for a premium lens, the patient should come back to me before fixing up the date. Patient should not go off from your room, fixing the date with a premium or a multifocal lens or a eye lens, because I have to cross-check certain things. I have to look into the other eye. We promise him both eyes. How do I know the other eye doesn't have a cylindrical power? And how do I know that he'll still afford a cylindrical power in the other eye or not? Cylindrical multifocal with cylinder, with toric lenses. So these things have to be taken up. The doctor has to recheck the patient if they agree for a multifocal or a head-off lens. And the third point is look into his habits, both attitude, habits in terms of attitude, and habits in terms of his working environment. So these also do play a role. You have to decide whether this person will keep on complaining or will accept to a multifocal lens. So these 3 things are the criteria to select my patient. We give the option, finances, patient decides.
I think that is well said, and more so in a practice, wherever practice is being done. So these 3 are important parameters to guide on the selection of the lenses, intraocular lenses.
Okay, this is the 3rd case. I do not know, there is no injections given. How did this gentleman develop a clot? Did you, while cutting, inject something? No. Okay. Can I have the slide of this gentleman? Okay, he is a 58-year-old male. Akshay Babu, apanakara surgery telecast hochi, hala? So I would like to have your permission for that. My friends across the country are seeing. So he is a 58-year-old male who has pseudophakia in the other eye and 6/18 in this left eye. His K value cylindrical power is about 0.65, I think. I can't see that properly. and he is being given a techniques synergy of plus 21. And again, this is a variant marker where it says that 0.6 means you need to do a additional cut across the opposite side. Okay, next. Register the patient, please. Good. How come the variant finding here and here are different? Huh?
So you use this variant for almost all your cases?
Yes. That helps me in at least designing my incision, nothing else.
Yeah.
So if you see here, it is giving us the location of your primary incision and the location of your secondary incision to decrease the cylinder.
So you already made an opposite clear corneal incision, huh?
Yes. So I expect that if I am inducing a 0.2 cylinder here, I'll also induce another 0.2. So that would probably neutralize about 0.4 from the 0.6 pre-existing astigmatism.
These are all 2.2 millimeter incisions, right?
Sorry.
These are all 2.2 millimeter incisions?
Yeah. The side ones are 1 millimeter.
Yeah.
Side put ones, and these are 2.2.
I think there is a question that at present most of us practice by quoting price of lens and charging surgery charge as per the lens. So yes, that is very correct. And of course, the surgical fees would be there, which will probably be the same. But as per the lens that is being used, the charges would be different. And I think that goes in government institutions as well, apart from the private institutions. Only thing is, we probably don't have a surgical fees for the patients who are in the general ward. But again, for our private ward patients, we do have a surgical fees, which is additional to the charge of the intraocular lens. So I think all of them are cataracts which require trap and blue staining of the eye.
Good.
But completely effortless chopping. Perfect, absolutely.
So for this chopping, are you using a sharp chopper?
Yeah, I use a sharp chopper with a sharp tip also.
Sharp tip.
And it's a long one, 1.5 millimeter to 2 millimeter. That's my chopper length.
Yeah, it is a chopper which is sharper than what we also use. I mean, the tip is sharper. And this is again a harder cataract. So this way, I think in till 5 o'clock we'll finish all 16 cases, Dr. Ashok.
Without the live surgery, I would have taken till 5:30. I would have finished.
I know. I'm sure.
Because this is a routine every day. It's the same thing. I have to finish one, go and do the other, all lined up. Okay, so this gentleman has already undergone a multifocal lens in the other eye, so we are giving synergy in this eye.
And when was the last surgery done in the other eye?
Sir, आपनका आराकी कब इतला? About 3 months back.
Okay. It is a good way of doing things, like you aspirated from bimanual irrigation aspiration, removed the aspiration probe, kept the irrigation probe, and then injected the IOL. So that saves a lot of your time.
Yeah, then see the main point where the patient complains of pain is when you make the chamber shallow. When you allow the chamber to become shallow, there's a stretching on the ciliary process area.
Absolutely.
So if you keep the chamber tight all the time, that is always good. This is another important point to, as you said, Dr. Rajesh. In a myopic patient, never allow the chamber to become shallow.
True.
Before you remove your irrigation cannula, you must make sure that you have put some viscoelastic or something, so that it remains tight all the time.
True. Tight and uniform. Otherwise, shallowing, and then again, if you deepen again, the patient will have problems.
So this is how you can actually, when you're removing, form the chamber and then remove. So it remains shallow, it remains deep.
This is again a very nice point that has been highlighted, that by this technique, you never allow the chamber to become shallow.
Baba, take a light with the contour. I'll just check for the centration of the lens. Okay. Remove the variant mark, please. So you can see the central bullseye is in the center of the variant mark.
Yeah.
I just tap a bit more so that I am 100% sure it stays in place. Good. If you do not have a variant, then also you can see the 3 light reflexes, Purkinje reflexes from the
Purkinje reflexes, yes.
Yes, the Purkinje reflexes are to be compared. It should be within the bullseye, the central part.
Absolutely.
Thank you. Marla Ichega.
So,
okay.
So we already through with your third case for live surgery demonstration, and we'll have the 4th case, I think, finished by 4 o'clock. So definitely you'll be in a position to at least double by 5 o'clock. So what is your experience of this synergy lens? Your and which multifocal was put in the other eye? If you can just tell us a little bit about that.
Technics multifocal.
Okay.
Not a synergy.
Okay.
Can you do you mix and match your multifocals?
Well, this gentleman is a retired person, and he said that he is interested in reading with us. That is what he was interested in. He said, I'm a voracious reader, I'd like to read. So that is why we decided to give him multifocal in both eyes.
Okay.
Now, the question is, when we decided to give multifocal, why did I give synergy in this? First, because this company wanted synergy to be implanted. That's the first reason. I would have probably given a multifocal. The second, synergy I do not have a vast experience of giving a lot of synergies, but synergy does give a better contrast, if nothing else, better contrast than its counterpart. So if the contrast is better, the person, when he is reading, probably will be a little more benefited. So if you notice here, the patient had 20.5, but I gave 21. Again, the purpose was because synergy, you can expect slightly, M6 with difficulty. So I intended to give this gentleman 0.5 more than 20.5, so that I wanted this patient to become slightly more myopic, 0.25 to 0.5 myopic, and he would be more comfortable reading. And of course, over that, he gets a better contrast.
So if there is a patient who has a eye hands in one eye and then now wants a multifocal in the other eye, do you mix match the EDOF with the multifocals? No.
No.
And if a patient has monofocal in one eye, then would you be okay to give EDOF or eye hands in the fellow eye? I think we all agree on that is acceptable, but we don't try and mix a monofocal plus with a multifocal. Multifocal of various other companies, is it okay to mix like synergy with PanOptics? Do you like to do that?
Yeah, I have done that. I have not mixed match synergy with PanOptics. There are people who have opted for, multifocal from one company and multifocal from another company because the cost factor. That I have done. People have been happy.
Okay.
Right. So an Indian multifocal would cost them about 10,000 rupees less than an important multifocal. So there are people who for the second eye have come back and told me there are issues with some finances. So can it be done in a cheaper way? I have counseled and they have been happy.
And
I do feel that for some reason companies hike their toric counterpart prices, and I do think that should not be done. I mean, I think we can only request J&J and other companies, because just like in spectacles, your sphere and your cylinder is there and you don't hike prices if your cylinder is there. So likewise, I mean, I don't think there is anything for multifocal we can understand, for EDOF we can understand, but for a toric IOL, I don't think they should actually hike. There should be a difference between a sphere and a toric IOL. What do you think about that?
Yes. Actually, you are correct. Though the manufacturing process is a little more cumbersome in toric, so they are right in increasing the price, but not to the tune of double.
Yeah.
It's little more than double also.
It's more
that
than
is not justified.
Yeah.
And see, they should understand that if it is affordable, the number of sale can increase. Toric is nothing very great that people will not adapt. People are not adapting because they are afraid that they are going to promise something and not attend it. But if the prices are down, they don't need to promise. They have to select the eye and tell that, okay, for you, this is the lens required. But when you ask somebody to pay double and tell him that, okay, I'll get you free from spectacle, that is why we are giving this lens, then that causes some sort of an inhibition over. This is right eye? Okay, good. So that is an inhibition of the person mind saying that I promise something in case the toric lens does not fit in. There are surprises. I have had a patient where I had to pay back the full amount because the patient's residual power was 1 diopter. He had 1.75. Post toric, everything as per books, residual was 1.0. So he said that I will not accept this. So you have to pay my balance amount, what you would have charged for a monofocal. So I had to pay him back. So these things do occur. Surprises are always there. We'll come to that side.
So I think, Rajesh, we are now discussing about lenses because we are beyond surgery. The surgery is so effortless. There's hardly anything, to discuss there. but it is more about intraocular lenses because the steps are absolutely textbook-like, and they are, absolutely ideal.
Very quick.
Thank you, ma'am.
He's very quick. And most
variant
importantly,
nahi hai?
I
variant?
really appreciate the way you have planned your surgeries. I mean, that's how you do always. So it's always a planned surgery. Every step is linked. And what I could figure out in last few cases that we saw, that the chamber was never shallow. It was always maintained, well maintained throughout the procedure. So
that's the beauty of most of the new machines. Now the chamber stability, somehow the technology of maintaining chamber stability has been really good for most of the new machines.
Yeah. So this is a 50-year-old female, a little younger female with 6/18 visual acuity in the left eye.
Oh, sorry. So I'm supposed to say that.
Yeah, and keratometry is 44.8.
Astigmatism.
Yeah.
Okay.
So again, a synergy lens with a power of 20.5. So can we move to the operating microscope, please, now? Can we have the operating microscope view? Yes.
So similar to the last case, I'll also do a LRI. Modify, I would not say LRI, another incision. Go to Rexis. Somebody has not planned it properly. This Rexis is not 5.5. You are misleading me, my friend.
This looks smaller than 5.5 actually.
I know. My optometrist probably is hungry. And angry with me.
It's a perfect circle each time you do that, and that is why I said this forceps or your hand, rather than why give the credit to the forceps. It's absolutely, all have been such perfect circles.
Acha, there are a lot of people who do too much of hydro dissection and keep on rotating the lenses. I think it is not really necessary, because just a fluid wave and you tap, your lens is loose. So you can know by just doing like this. So you can see the lens is free. So it saves time. You don't need to waste time by rotating and putting more effort on the zonules. From the rest of the lenses, from the rest of the surgeries, can you check any hard cataract or any white cataract, anything like that?
All of them, in fact, were grade 2, grade 3 cataracts. None of them were very soft cataracts, actually.
All were grade 3 plus.
But 2 days before JMJ, people came and were watching my OT. So they were thinking that, like the last 2 days, today also I'll have a lot of difficult cases. I do not know. Today probably I'm a lucky person. Today morning I got an award from the state.
Okay.
Every year the capital city celebrates Foundation Day. Today is the Foundation Day of 74th Foundation Day of Bhubaneswar.
Okay.
And they select about 13 people from different spheres and award them as Rajdhani Gaurav. Rajdhani means capital. Rajdhani Gaurav. I got a award today in the health sector.
Wow, congratulations.
Many congratulations to you.
Thank you, ma'am.
For the same.
So I think today is my lucky day, so no more difficult cases.
It is good. It is good that, all the cases are simple. I think classically the fragments they get, underneath your wound or underneath your side port or underneath your iris.
Yes, especially if you have the viscoat on, they
Yeah,
keep on sticking to the.
yeah,
If you do it only with methyl cellulose, they float, they come.
yeah.
But here they stick. Light ko dekhun tuma. Good.
So I think there's another question: what linen do you use? Because sometimes there is a problem of linen fibers which are going. So do you use linen-free gowns or linen-free, or do you use powder-free gloves, or do you
No,
use?
I do not use routinely powder-free gloves. When my hospital has some extra money and purchases, I do use, but I do make it a point that I wash my hand. I do not change my gloves after every case. I change it after about 6 cases. So I wash it. Once I change my gloves, I wash my hand. And linen free, yes, of course, on our OT trolley and with the patients, we have linen free plastic sheets.
I think the machine is also so predictable. The fluidics are so good. There's hardly any surge. It gives you a complete control. And I mean, at no point in time, the AC becomes shallow or you are caught unawares. And the fluidics of the machine that you're using are also very good.
Yeah, the machine.
And I think this hydro implantation, you've already, one step is already gone of aspirating the viscoelastic. So that step is already obviated because it's hydro implantation.
Yeah, it saves time. Whatever steps I do, most of them are basically designed to save time. So as a typical textbook steps, what you are saying, I don't follow many because I feel most of them are only necessary when you are doing in your initial couple of years of your practice.
No, but I mean, these are modifications of, I would say, textbook style, and these modifications have a logic. So, I mean, whatever modifications you have done, they are based on certain logic. So, like the hydro implantation, it does save time, and particularly in toric implants, it will be of great benefit that you are absolutely sure that there is no speck of viscoelastic left. Now you have a haptic stuck onto the optic.
I'll just wait for 20-30 seconds.
Yeah, I was just, I was also waiting for that only, that the haptic will detach by itself.
Yeah. It is only in one company, Indian company, where it sometimes sticks and doesn't open. You have to actually intervene.
Okay.
But in all other imported manufacturers, this normally takes hardly 20-30 seconds, especially when the OT is maintained at 20 degrees.
Yeah.
There are friends who who put the lenses in some sort of a box with a light, 100 power light bulb.
Okay.
So there is a little nasal shifting of the lens, so I'll try to readjust. Okay. Remove the centration mark. Okay, now it looks okay. Now, bhala each operation. Thank you.
Do you inject intracameral antibiotics at the end of the procedure?
Sorry?
Do you inject intracameral antibiotics?
Yes. Since 2007. The first paper which I read from Dr. Abhay Vasawada, that was my changing point. I have started injecting from that time itself. 2007, I think. I remember it should be 2007. All cases. Somebody asked me, how do you know that you are injecting 0.1 ml? So I said, that's again a practice. You can never look at your syringe and inject. You know, you are already looking through the microscope. So it's a practice. My intracameral xylocaine is also 0.1 ml. So on an average, about 8 to 9 people are benefited from one syringe. Same way, this is also the same.
So I think that question has come again, which capsulorhexis forceps you're using. So we were all admiring your capsulorhexis, and I think you've already answered that it is Haldipurkar capsulorhexis forceps that is being used.
Right. So I'll shift to the other table. Okay, so this patient I'm sitting on the superior part because this patient has a combined surgery, retina surgery to be done after I do the cataract surgery. So for retina surgery, they always want the incision to be on the superior part, irrespective of whether you have a deep socket or not. So Sangamitra is standing here and laughing to see whether I'm able to do a deep socket eye or not.
Dr. Madha Rao from Berhampur has congratulated you for being conferred with Rajdhani Gaurav Award. And
thank you.
And he said you really deserve it. I think you more than deserve it.
Thank you, ma'am. ना तुम एक के मोटा मा भूल कर जो कि हाँ सेंट रखियो है और ठीक है तौड़ को देखो मा चेंज करिए घंटा शोक आजी कौटी शोई So the trick of doing your axis is that you follow the axis, follow the margin of the pupil. That is the most important thing. Wherever you are pulling, make sure that you are equidistant from the pupillary margin. And keep grasping again and again. The line, rhexis line, which is shown by the variant, is a guide, and you know that okay, that's the approximate size for 5 millimeter rhexis. And based on that guide, you look at the don't look at that light. You look at the pupillary margin and do the rhexis. That's how.
So I also see that your angulation between your main port and side port is, of course, guided by Virion, but it is exactly not 90 degrees, but it is about 40 degrees. So every time it is with the help of the Virion that would make your side ports.
No, before the variant is about less than a year old now. But
Okay.
before that also my angulation is usually 45 to 60 degrees.
Okay.
Sometimes 45, sometimes 50, 60, within that. It is not beyond that. I don't prefer to keep it at 90 degrees.
All right.
It's that is variable. That is not a point where people should think that this is good for somebody or this is not good for somebody. So whoever is comfortable at 90 degree can take it at 90 degree. 1 millimeter incision hardly makes a difference in your outcome. How much of time one should actually give to capsular polishing? Is it really necessary to completely polish the anterior capsule as much as possible, or you can just do a polishing at the rim of the
So I don't. What actually happens is that whatever this is just a what do you say, instinct or spontaneously. Whenever you see any cells on the anterior capsule, or for that matter on the posterior capsule, if there are some shreds of cells there, then you want to do it. But if you look at the publications, etc., then it is said that polishing does not actually matter as far as the capsular opacification is concerned. Dr. Vasavada did a study where in pediatric cataracts, he polished half of the capsules and half he did not polish. And there was no difference in the PCO. So I really don't know how much difference it will make. But having said that, it is a immediate instinct, whenever you see that either on the anterior capsule rim or on the PC, you just want to, make it smoother.
Okay, so you can see there's some cells here, some fibers here, which would be benefited by just doing a hydro polishing.
So I think this question everybody asks us, and again, there is a question which has been asked in the chat box also, that if the patient is an ophthalmologist, what lens would you advise for your fellow ophthalmologist surgeon? What lens would you advise if there is a cataract? And he's an active surgeon who is going to be doing surgery.
Your question is what lens you would prefer for an ophthalmologist?
For a friend who's in practice in ophthalmology, is a surgeon, and he's actively going to do cases later on also.
I would still prefer a head-off lens like Ihans. Yes.
Okay. So I saw in this case you slightly increased your wound size, which you've not normally done in all the other.
Yeah, this was a lens from Hoya.
Okay.
I have found the Hoya lens going through smoothly through temporal wounds, but when you do wound-assisted delivery from the superior
Then-
side,
Then it
normally
becomes-
they sort of get restricted.
Hmm.
So I try to do a 2.6 for a superior incision. That is my personal experience with Hoya lenses.
Okay.
So I'm leaving the viscoelastics here because the retina surgeon would be completing the surgery with the antechamber filled up like this, and it will be removed after the retina surgery is over.
Okay. So this patient is planned for combined cataract and vitreoretinal.
Yeah, we will shift the patient to the next OT, retina OT.
Okay. Okay.
So how many in your practice, how many cases would you have where you would have to combine cataract and vitreoretina together? Once a month or maybe twice a month? Or...
No. It's much more than that, ma'am. Actually, retina numbers are not that less. You just need to diagnose them.
Hmm.
Partial lamellar macular holes, ERMs, vitreomacular traction. These are very common. 10%, I would say. That's what I find in my practice here. That about 10% of patients, when you feel that retina is normal, and you see post OCT that there are problems which needs, probably it can be tackled in the same sitting if the patient is willing. अच्छी हाँ नहीं superior कर again
Normally, in our kind of setup, what happens, because we may not have a retina person operating on the same day, because two units combine together and do the OR. So they would first request us to do a cataract surgery, and then maybe after 3-4 days or after a week, they would then do the retina surgery.
Yeah, my retina surgeon also operates twice a week, but
Okay.
I operate every day. So I schedule my cases on
You
those
set a
days.
manner. Yeah,
She is
set a
operating.
manner. Okay. So don't you have to suture the wound, because our retina person insists that you put a single suture there on the wound. It's probably easier for him to do it with a suture.
Yeah, but if you put viscoelastic,
Then-
it still stays. No, I
Yeah.
don't think there's a need to suture it if the visco is there. So all that I tell her is that you remove the visco when you complete your surgery. Sorry, कर दीजिए. So this is a softer looking mature cataract. And change करते. What about your post-operative regimen? And
Post-operative, yeah.
Yeah, normally in my case, I give steroid for 2 weeks,
Okay.
and then NSAID. That's what I do 4 times a day for 2 weeks, along with the lubricating drop, steroid antibiotic combination, and a lubricating drop for 2 weeks. Lubricating continues, and NSAID is changed.
Okay. You don't give cycloplegics in all the cases? Like
No.
Okay.
100% no.
Okay. So just topical antibiotics post-operative.
Yeah, topical antibiotic 4 times a day, steroid antibiotic combination, and NSAID after 14 days.
Okay.
So after 14 days, you stop steroid antibiotic combination?
Yes.
Okay.
Yeah. No tapering, nothing. So that has been my practice for last 10 years.
So we normally like to give it separately. So topical antibiotics for about a week, then topical steroids 4 times a day. We give, and we do taper topical steroids over a period of about a month. And then topical cycloplegics we do add for the initial 7 to 10 days, like a tropicamide or a short-acting one.
The reason for giving a topical this one, cycloplegic?
So I think that is something that we've been doing for so many, for the last so many years.
Yeah.
And somehow
So actually, in 99% of cases, we don't require to put it, and that's why it's the old habit. But I have reduced it down to only 3 days. Maybe after some time I will stop, or maybe just use it in selected cases. So I feel in 95-96% of cases, the patients don't require cycloplegic at all.
Because you are putting the lens in the bag.
Yeah.
Yeah, and mostly these surgeries have become so smooth and atraumatic, and the risk of post-op reaction is absolutely negligible. So I think maybe what one can do is that in the post-op period, one may evaluate on day 1 and then see if the patient does require cycloplegic. One may give it, or otherwise there's no need at all. That way, I would agree with Dr. Nanda. And I have also reduced it to only 3 days now in the post-op period.
There was a mistake in this patient in my surgery. Talking to you, I forgot to do chopping of all the 4 quadrants. So I just did 2 quadrants and started eating. So if you do only 2 quadrants, start eating the quads, then the second half freely floats. So you really have a tough time to again hold it properly and chop. So this is something which should not practice. Ideally, if you are cracking or chopping, you have to chop the complete nucleus and then take piece by piece. But if you just chop one half and eat it up, the second half floats, and then holding it and chopping becomes a little difficult.
But the speed with which you finished it, we didn't realize that into the previous question only, and the nucleotomy was over.
In a mature or hypermature cataract, you are likely to have a loose posterior capsule. So when you are polishing, it is likely to come to your tip. So one has to be a little more careful in a PC polishing in a hypermature cataract. What about putting in a CTR in all mature or hypermature cataract? Is it a practice, or is it a good practice, or you think it is not necessary?
Polishing, I think sometimes when the capsule becomes really friable, and at times it is so flimsy that you are scared to polish, even though there are single strands which are present there. So I think it is a good practice to just leave it at that point in time, especially hypermature ones, and the bag is also a little loose and everything is trying to come up. So I think I would completely agree with you that in those points in time, one can completely leave it and not go chasing it.
So this is a yellow lens that you are implanting.
The Clarion. It has also a self-injecting system.
I think
Where you just have to keep.
yeah, it's automated and which uses carbon dioxide.
Yeah, the gas keeps pushing the lens.
Yeah.
So without admitting that this is a glistening free material, they promote still a lens which is now glistening free from that platform. But it's definitely a much better lens than the IQ platform.
Yeah, I think the material is far superior. And there is a question there that after 2 weeks post-operatively, which NSAID would you prefer, Dr. Ashok?
I recently did a study and published it where I compared different NSAID and I found that Nepafenac 0.3% is the best. In my paper, in about 500 patients, I compared different NSAID and the best result was with Nepafenac 0.3%, once a day dose. That was the result that I got, but I prefer any form of Nepafenac 0.1% or 0.3%, doesn't matter. It is better than Bromfenac as far as inflammation control is concerned.
So what about Elevro? Have you tried Elevro for?
That's what we're talking about, no? OD, Elevro is OD, which is 0.3%.
Yeah, that's what I'm saying. Elevro is 0.3%.
Yeah.
Nepafenac. I tried Nepafenac, Ketorolac.
Yeah, and giving OD dose also has a good compliance actually, and patient is also happy that way. If it's working and if it's an OD dose, then definitely compliance also is taken care of.
Yeah. In most of my high-risk cases where there's the patient with diabetes or patient who has uveitis post-glaucoma, so all those patients I start Nepafenac once daily, 0.3% once daily from day one, along with steroid for 2 weeks, but the NSAID starts from day one. Baba light ko dekhiye na, hale beni flash kara.
So can we have the microscope view, please? So can we have the operating microscope view, Gaurav? We are seeing. Yeah, we are seeing the external camera, but can we have the internal camera of the microscope?
There's somewhere there's a loose cable. if we discuss a bit about techniques, so the technique of chopping is that you must start chopping from the, start digging from the center of the nucleus and go at least halfway to the periphery. If you are not going halfway to the periphery and just keeping your tip at the center, then the chop becomes difficult. So your tip has to go deep to at least 50% or more than 50%.
We can't see.
Gaurav, can we see the operating microscope view?
Their cable is there's some problem with the cable. That's what they're saying.
Okay.
So, Dr. Ashok Nanda, we can talk about your operation theater, which is modular. Do you think that there are more modular OT is more difficult to? What about the maintenance? Do you think it is more difficult to maintain, or you think it is a lot more safer and maintenance is not an issue?
Well, there are definitely positive points about modular OT. I would definitely recommend everybody to go for a complete modular or a partial modular OT. The airflow handling system has to be good. There has to be a laminar flow. There has to be a HEPA system. You are much more safer that way. Maintenance cost, well, installation cost is high. To make a modular OT, you have to spend on an average about 15 lakhs per OT. But then maintenance is not high.
Okay.
You just need to change the HEPA filter once in 18 months to 2 years. So which is costing something around 30,000 rupees per OT, which is fairly good. Not. I think it was 60,000 something for both my OTs.
Okay.
And the rest all the cooling system are routinely maintained. You just have to pay them when they come once a quarter. नहीं हो रहा है कन्नड़ पानी पहुंची
I think they're trying to do it, trying to fix. There is some technical issue which they're trying to fix. So I think that is a good thing, because the common and the general understanding is probably it is more difficult to maintain. The recurring cost is much more, and also probably cleaning it, or maybe the cleaning protocols are more difficult because it's behind the steel also that you may have to go and do those things. But I think it is well said that modular OT is the way to go nowadays, and it is possibly more safer.
NABH, another point is NABH most of the times would obviously want a laminar flow system in your OT.
Okay.
So there has to be a single one-way entry, one-way exit. So all these factors do obviously make your OT much safer. Touchwood, I think for the last 9 years in my OT, there has been no instance of endophthalmitis.
That's a...
Yeah, that's...
And since how long you are using this modular OT? When did you make this?
That's about 3.5 years now.
Okay.
But
even before
OT also, sorry?
Even before you were taking all the necessary precautions that have been described, so probably that's why you never had an endo.
Yes, we had a air purifying system installed in our OT before also, but that was a makeshift one. HEPA filter installed in the OT with UV light and all that stuff. But what is more important is how do you keep your OT clean? How do you sterilize it every day and send for cultures and all that? So these things are important. You need to monitor those things. Your autoclaving.
There's a question that how long do you continue the OD Nebafanac in post?
If I started from day one, it is 6 weeks. If I started from day 15, it's for 1 month.
Okay.
My total duration of treatment is 6 weeks in any way,
Okay.
unless the person has uveitis or something where it is for 8 weeks.
Okay. Okay.
And if you have to give glasses at all, which possibly in these multifocals you don't have to, but monofocals you would have to, what time would you prescribe the glasses?
For multifocals?
For monofocals.
Monofocals, what my routine practice is, I call the patient after 1 week. I don't call them on the next day.
Okay.
Okay. And all those who are going to office or they need glasses, I give them after 7 days. Those who, okay, those who are retired or those who can afford to stay for a month, they come back after a month and take the glasses. So my first checkup is 7 days, then 1 month. Tight up. I think they have sorted it out. They should be able to. Hey, what is wrong with this?
There is
something below this.
some special effect coming from the back.
Yeah,
I know.
it's looking like a topography on which the very honest.
So too many cornea people on the dice.
Yeah, that is. That is why we are imagining Pentachem on your. I'm sure. I think now with the advent of the diagnostics being linked to the operating microscope, anterior segment OCTs and posterior segment OCTs all on the operating microscope. So there are going to be, and like the Verion thing, which allows you to see your main wound, the side port. I'm sure more and more diagnostics, including the topography or including the keratometric picture, is going to be there integrated with your operating microscope, so that then and there, things are sorted out rather than having to wait on a next day.
Yeah, that's why cataract has now become a refractive procedure now. So.
Yeah. So I feel more and more of such modifications will come, and more importantly, I think they should be made available to everybody, and they should be inexpensive. As of now, the cost prohibits the use of these devices at all centers and by all surgeons. But that is something which the company.
So that is an important factor. The cost in ophthalmology is really, really prohibiting.
Yeah, it is really prohibiting. Yeah.
Every time you purchase a machine.
Maybe with time you will have more manufacturers, and then the cost, there will be competition, and then the cost will come down.
Yeah, I think Indian companies have to come forth, because only when indigenous things come, then the cost really comes down immediately. Of course, yes, now we can get the signal very well.
Light को देखो तो क्या?
So this looks like a Rexus, which is 5.5 truly. I mean, the one which is projected onto the cornea.
I'm just waiting for these people to fix and tie up that loose wire.
Okay.
So I can start again. Okay.
That's fantastic. Just in four, like it's like a 4-quadrant Rexes, wherein four sweeps and the whole thing is completed. What a perfect mastery
And
of.
repeatability of a circular central capsular axis is 100%.
Okay, this is a case which is pretty soft. So my technique of surgery in a soft cataract is a little different. So I don't do typical sculpting, making a ball. No, I do a stop and chop. So I go to sculpt mode. Right. Once you are through more than 70% depth, then it becomes much easier, even if it is soft cataract, to just separate in the center. So it breaks into completely two pieces.
Very nice.
Yeah, very nice.
And your hydro has to be good. Otherwise, this is difficult to rotate. Even if it's not rotating fully, all that you have to do, just have to hold it. Sorry. Notch the tip out. Yeah, once, sorry. So once it is out, then you have to support it behind. And it.
Yes.
So you don't need to make multiple pieces here. Just support it and eat it. So you don't allow it to go back into the bag. And because it is soft, you are hardly using any power actually. So even if you are eating it in the antechamber, it hardly matters.
So I think sometimes you have this kind of a material which is, too little thicker for your irrigation aspiration. And if you use a phaco probe, then it will become, too thin for that.
Yeah, but then see, soft cataracts, epinuclear plate in the soft cataract is usually not difficult to. Yeah, you can go into visco mode and aspirate out. Visco mode will have a little higher aspiration rates and higher vacuum, so it can easily be aspirated out in a visco mode. So you can keep a setting which is slightly higher than your normal cortex mode.
So you do have some epithelial cells attached here and there, and with your this diamond dusted tip, you polish it and clean it.
Yeah. This is fine now.
Yeah.
Cool. Nice. So I'm going to insert a toric lens from the house of Jais. wash.
So I think we've demonstrated all the possible intraocular lenses which were there right from Johnson and Johnson lenses to Hoya, then uh, yellow lenses, and then now a Zeiss lens. So in your inventory, I'm sure that means all these lenses are available and you pick and choose depending upon the criteria, depending upon the patient to patient.
Yeah. J&J toric lenses are in short supply, so I had to look into other options where it becomes a little more affordable. J&J has given me torics at a little cheaper price, so I cannot equate J&J price to Alcon price. So I have to look into other options which are possible in that package.
Yes.
So Zeiss has come in that bracket. That is why I have started using Zeiss, and I have been using it for last 6 months. I think the results have been quite satisfying.
So any difference that you encounter with the plate haptic design and open loop design?
So the only problem in plate haptic is that in a high myope case, when the bag size is big, then you are little in a soup. Otherwise, for most of the cases, this is quite okay. Okay, so this is fairly centered, and the placement is also okay.
I think we'll finish your entire list in the given time period. We've never had so many cases in a single slot.
And we will see all sorts of lenses.
Yeah, it's been
like yellow, clear.
It's been like a marathon, and I don't think in any live Surginar we've had such a large number of cases. We can just attribute it to Dr. Ashok Nanda's brilliant surgery, and so predictable and so repeatable.
I should have selected some more left and right. If it was there, you could have finished 2-3 more cases by this time.
Yeah.
If initially you had to do only left eye, that's why you had to wait for the patient to be draped.
Yeah, actually, J&J people wanted their cases to be first over. Then they said they can go ahead and do.
Yeah, no, but that's amazing.
Flush, please. I light to the Kyoma. Okay, what about specular microscopy? I do routinely specular microscopy, but at what counts? I mean, what are your criteria to use a viscoat or explain to the patient about a post-operative edema? Look at the light to the contour.
So I think that is fairly defined. If the counts are less than 1,000, then we would all like to use viscoat. And also we take into consideration pachymetry, but we don't routinely get it done for all our patients. But specular microscopy, again, we are not doing for all our cases, but only in those cases where clinically you suspect that there's going to be fuchs, or there's a metal beaten appearance, or there are pigments at the back of the cornea. It looks, like a early stage of fuchs. So only those cases we are getting specular done. Otherwise, routinely for all our cases, we are not getting specular done. And of course, when the counts are still lower, say about 700, then we always tell the patient, or 500, we always tell the patient that post-operatively there may be a requirement of a endothelial graft, and so the patient needs to be prepared about that.
And you plan to do it in the same setting, or you do it in a separate setting?
Always, almost always sequentially, unless it is so hazy that you can't see and the visibility of the cornea is compromised. if the visibility of the cornea is compromised and the corneal thickness is more than 650 microns, cells are less than 500, then we would do a combined procedure, which would be a DSEC triple or a DMEC triple. But otherwise, I think it is always better to go sequentially, see how it goes, because for all you know, most of the cases will still be clear and will not require a graft.
Routine practice of doing a specular is good for obviously legal purpose. Okay, yeah. That's the first thing I would say. Specular doesn't cost much, and doing it takes hardly any time. Second advantage is that you have the option of research work. So you have the records with you. Third, of course, you tell the patient about it, even though you do a good clinical examination under the state lamp. Still, evaluating and telling the patient and showing them is something different, where you can tell the patient that yes, your cell count is like this. So I think in a practice, it is ideal that you do it in all cases.
Yeah, that's the ideal way to go about it. And a safe way.
Again, this was on a harder side, and yet I think the most important is the first chop that you make, and once you've got your fragments separated, then things begin to fall in place very easily, and your axis is correct, as has been so nicely demonstrated today. Then I think 50% of your job is done. But this is for the surgeons who are beginning to learn. It is not as effortless, as simple as it is appearing in the hands of Dr. Ashok Nanda, because he's a dexterous and an experienced surgeon. Everything is looking very effortless.
So I think this will be the last case before we go off the air. I'll have probably some more cases after that.
Surely.
And I think I must once again thank you, Dr. Namrata, Dr. Rajesh, and others, the AOS team.
We would like to thank you for showing such wonderful surgeries. Very nice surgery.
I think we would have done 10 cases, Rajesh.
Yeah. And very smooth, actually, fast and smooth, and everything as per textbook, as described. So that was a good learning experience, actually.
There's a question, which microscope and camera system are you using? Because everything is very clear and well focused. This is a question by Dr.
Topcon 800 microscope.
Okay.
And I have a Sony A7 camera. My retina colleague took away my Lumera eye microscope to her OT.
Okay.
He said, you cannot have the privilege of doing cases. Either you purchase one for me or take back mine. I said, okay, let's exchange.
No, but the transmission is really very nice. Every single vessel, every single fiber can be seen. Is this AutoCert which is being used to?
No. I told you that. Hey, do you have the AutoCert working? I don't know. I probably have not used it for last 4 years.
Okay, okay.
So this is an IQ lens or what?
This is IQ, yes. Look at the light. Light ko dekho ma. Look.
Okay. So thank you so much for a wonderful surgical demonstration of cases from your operation theatre.
Thank you, ma'am.
Thank you so much. For everybody, I'm sure everybody's benefited a lot today without having to visit it, only from their desktops and laptops. And I think that is the idea of the Surginar, that the surgeon operates in the comfort of his operating microscope, and the people who want to watch can watch from their own places without having to visit. And I'm sure many of them would want to now visit your wonderful operation theatre and see a modular OT, which is so unique, which also has a scenery. It looks you're, operating in some exotic place. But thank you so much today for all your time, for your efforts. Thanks to your team. I'm sure they must have made a lot of efforts organizing, collecting cases, and then showing us seamlessly case after case, so thank you, the nursing staff there, the assisting people there, and everybody in your hospital. And of course, we would like to thank Johnson & Johnson for sponsoring this session, and the audiovisual team, Mr. Gaurav, and the AIOS headquarter team, Mr. Kripal, for coordinating and organizing the same. And we hope to have you again on another platform. So on another time with another set of cases. Thank you so much, Dr. Ashok Nanda.
That will be my pleasure.
Yeah.
Thank you.
Yeah, this was actually long due, and finally it happened. So, and definitely we would like to have more such webinars from your end. So thank you so much for such nice demonstration of the surgeries, and very nice discussion, fruitful discussions. Thank you.
Thank you, and many congratulations for your award today.
And yeah, once again, many congratulations.
Thank you. Thank you.